Almost. Okay, and we are live. Good afternoon, everyone. Thank you for joining our session today. We have the pleasure of hosting Dr. Nisha Patel, who will be talking to us about culinary medicine and internal medicine. As always, please remember the Google form to track your attendance will be posted in the YouTube chat box at the very end of the session. With that being said, Dr. Patel, you can get started whenever you're ready.
Hey everyone, happy Thursday. I almost forgot what day of the week it was. So I just want to say thank you to the web shadowers for allowing me, giving me this opportunity to talk to all of you about a subject, a passion of mine that I've really just taken a hold of and ran with it. So I appreciate the opportunity, and thank you all for being here today to hear me out, hear what I have to say. So I just wanted to start this talk off by giving you a few objectives, some things I want to cover. So I'll tell you a little bit about me and introduce you to the field of internal medicine, and then talk about my journey into culinary medicine, and talk about what is culinary medicine and why do we even need this. And then I'll go over a clinical case, which is not based on a specific patient. It's actually a pattern of patients that I see on a regular basis. And so I'll talk a little bit more about that later. I'll talk about healthy eating patterns, maybe some culinary medicine tips and advice for your future. So I want to start this talk off by saying that it is never too late to start making positive lifestyle changes. And remember that progress is more important than perfection. So just keep that in mind as I'm talking. So a little bit about me. I'm actually from Austin, Texas. So I did all of my schooling in Texas. So I actually went to undergrad at the University of Texas at Dallas, and I majored in neuroscience. And I actually thought I wanted to be a neurologist for the longest time. So hence that's why I went there and chose my major. But as you can see, there was a time for 3 years from where I graduated undergrad and actually went to medical school. So I'm just going to touch a little bit on that journey, what that looked like. So I graduated undergrad in 3 years. I found myself, having finished all my credits, and so I decided to graduate. I didn't have the best GPA in undergrad. My freshman year was pretty rough, and I didn't do as well. And despite doing better my second and third year of undergrad, it still was suboptimal. And then I, unfortunately, when I took the MCAT multiple times, I kind of stagnated at a score. And so I actually applied to medical school in 2008, and I didn't get in, which was really disheartening. But I realized that, I couldn't give up. And so I decided to strengthen my application. And that's what I did those 3 years that I took off. So the first couple of years I worked recruiting for clinical trials. So I got kind of exposure to taking patient histories during that time. I worked with several physicians that were principal investigators that were very supportive of my decision to going to medical school. And then I realized that I still needed some more strengthening of my application, and I decided to pursue a formal post-bac program. And so that's what I did at UNT Health Science Center. And when I look back, that was probably the smartest decision that I made. I learned so much about medicine that year that when I went into medical school at A&M, I had this great foundation, and I graduated in the top few percent of my class. And so even though my undergrad was suboptimal, my MCAT was suboptimal, that didn't predict my future. And so I want you to remember that, okay, if you were in a similar situation as me. Once I graduated medical school, I went out west to the University of California, San Diego for internal medicine. As you can see, I did not become a neurologist. I loved my internal medicine clerkship during my third year, and I just loved seeing a variety of disease processes on the inpatient side. So I decided to pursue internal medicine. And then I graduated just a few years ago, so I'm not that far out of training. And I'm currently a hospitalist in San Francisco, and I'll talk more about what that is. And I'm pursuing my culinary medicine certification through a program called Health Meets Food. So what is an internist? Well, when I tried to explain this to my family members, I would, they'd give me like puzzled looks on like, what's internal medicine? And the way I like to think about internal medicine is that it's the care of only an adult patient population. I don't see children, I don't see pregnant women or babies, and we are skilled in caring for a variety of chronic medical conditions. So internists work in the outpatient setting, particularly in primary care, and they also work in the hospital. And when they work in the hospital, they're referred to as a hospitalist, which is what I am. And internal medicine really is like the gateway and foundation to a multitude of specialties. So if you want to be a cardiologist or gastroenterologist or go into hem-onc, pulmonary, infectious disease, rheumatology, you name it, it is the gateway to a lot of different specialties. So what is a hospitalist? I'm not sure if any of you have heard that term. A lot of people haven't. And whenever my patients know what that is, I'm like, where did you learn that? So a hospitalist is an internal medicine physician whose primary focus is taking care of patients that are in the hospital. And it's not just, we really take care of our patients from like the continuum. So, I'll see them in the ER, I'll admit them, I take care of them through the entire hospitalization, and then I help set up that care, that transition of care when they leave the hospital. But I don't do it alone. I work with a ton of different people, very, very vital members to the healthcare team. And that includes my awesome the awesome nurses that I work with, the social workers, case managers, our dietitians, our physical therapists, and a multitude of specialty physicians. So the environment that I work in is very unique. We have a very collaborative relationship with our specialists and our surgeons. And so I feel very blessed to be working in such a supportive environment. And what I love about hospitalist medicine, and also it can be frustrating at times, is that no 2 days are the same. When I walk into the hospital, I may expect the day to go a certain way, but then sometimes it just doesn't go that way. My patients are sick, they can get sicker on me. I'm constantly making decisions throughout the day. I order a lab test and it gets done. I can see that in like an hour or a few hours and be able to make real-time decisions. So I really do like that level of acuity is what it's called. And so that's why I'm doing what I'm doing. But then how did I get to culinary medicine? So, I grew up vegetarian, and a lot of individuals may think that being vegetarian means that you automatically follow a healthy diet, that you really love vegetables, and that you're kind of running around with broccoli in your hand. I don't know. But in reality, I was not the healthiest of vegetarians. And I'm South Asian, I'm Indian, and I have a very, 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 and I'm saying very strong family history of diabetes, as many South Asians do, along with cardiovascular disease. Both my parents have diabetes, their respective siblings have diabetes. Two of my aunts are on dialysis from end-stage renal disease from diabetes. And so I really, as I was starting to progress into my 30s, I'm 33, just to throw that out there, I started thinking more about what I wanted my life to look like in 30 years. And I realized that I needed to make some changes now. When I was in medical school and residency, I was out of the house. I was eating a lot of my meals out of the house. I was, growing up, I lived, like in my teens, I lived at home, and my grandma lived with us, and she made a lot of our meals. And so I did eat more at home at that time, but things definitely changed in my 20s. And it was starting to catch up to me. I realized that there were some changes in my own cholesterol panel and my own glucose panel glucose that I was worried about. And so I decided, got to make changes. But I made the mistake of, started doing my own research on Google, and I realized that there was just a plethora of information out there. And a lot of it wasn't evidence-based. A lot of it wasn't good information or things that I would even want to tell my patients about. And so I was looking for an evidence-based practical way to make these changes into my life. And around the same time, I became really interested in obesity medicine, and I learned about culinary medicine through obesity medicine, actually. And so I started doing my own research. And oh, by the way, this is how I felt about vegetables. And lacanophobia is actually the fear of vegetables. So that's a true thing. So I landed on the current culinary medicine program that I'm enrolled in. So what is culinary medicine? Well, I like to think of it as practical nutrition knowledge that helps one find ways on how to eat healthier and combines that with the science of medicine and nutrition. So it's not enough to tell somebody to eat more fruits and vegetables, right? Like, that's great. We know that. We all know that. But how are we going to teach them how to do that? Why do they need to do that? All of those things are really addressed by culinary medicine. You know, it doesn't dictate that you follow one diet or you got to follow this diet or stop doing that. It tries to use what's available to people, what's available to your patients, because not everyone has everything. And I'll talk about that later, and work with them, find that middle ground, and get them to an overall healthier eating pattern. That's the emphasis here. And we want to focus more on the pleasures of eating healthier foods versus saying like, avoid the wrong foods. I hope that makes sense. But, you know, a lot of times, and let's talk about barriers to healthy eating. One of my barriers was that I thought that healthier foods were not tasty and that they were boring. And in reality, that's not true. I just didn't know how to prepare them. I didn't know how to make them tasty. So that a lot of people may feel that way as well. Another barrier for me was that I didn't know what changes to even start making. You know, I was eating in residency. I had 4 like fast food restaurants that I was kind of rotating in between. And so that was just really like familiar to me. And if you looked at my kitchen in residency, there was like, I never used it. It was pristine and clean. So I never cooked. And I think trying to break that cycle, I just didn't know where to start. And then also, like I said, not knowing how to cook more healthy foods. Sometimes there's a lack of healthy food options and where a patient or a person may shop. So that's definitely a barrier. People think that healthy foods are really expensive or they take super long to prepare, and that's not true. I actually made kind of it was like a chickpea and red lentil like rice dish last night, and I roasted some asparagus, and that took me less than half an hour to do. It was really quick. And then of course, lack of time and lack of equipment. So I'll talk about that a little bit later too. So in the US, there's a trend towards, you know, eating more of our meals outside of the home. And we know that when we consume meals outside of the home, specifically fast food, these foods are typically lower in fiber, vitamins, minerals, and phytochemicals, which I'll talk about a little bit later. And they're higher in saturated fats, which I'll talk about later too, salt, and added sugar. And cooking overall, there's been a decline in home cooking over the last 40 years. So that you can see that the trend, this is, you know, eating more foods out of the home, and then this is cooking. I got this figure from the NHANES survey website, I should say. So the NHANES Health and Nutrition Examination Survey is like an ongoing study almost, or a survey of like the adult population, or the population. I think they survey like 5,000 individuals a year to see what their eating and drinking patterns are like. And it's been an ongoing kind of longitudinal survey. And so this is data from 2013 to 2016. And what you can see is that the percentage of adults 20 and over who consume fast food on a given day is quite elevated, specifically for those that are between the ages of 20 and 39. So if you look at this total, it's about 44.9%. It's pretty high. And then you look, also some information from the NHANES survey between, I think it's 2017 to 2018. So you can see that no matter how you look at it across the age groups, the prevalence of obesity amongst adults aged 20 and over it's above 40%. And then I liked this pictorial a lot because as you can see in 2004, there's not as many dark blue areas in the country. I mean, you see some concentration around the Southeast. And as time has gone on, in 2016, you can see that there's more areas of the US that are in the dark blue range. And what that's signifying is that the diagnosed diabetes prevalence is increasing in adults over 20 and older. So we know that the direct and indirect cost of all chronic medical conditions is $3.7 trillion, and about half of this is influenced by the chronic diseases of obesity, overweight, and the diseases associated, such as type 2 diabetes and cardiovascular disease. And guidelines that are informing nutrition policy are really evolving away from like the do's and the don'ts, and evolving towards encouraging more healthful eating patterns, which hopefully are easier to carry out. At least it was for me. And then I want to talk about eating behaviors. So one of the kind of tenets of culinary medicine is understanding the behavioral aspect of eating. And as you can see, eating behaviors are complicated. So you not only have your own individual factors, you have your social network, you have the physical environment that you're in, the macro level environment, which includes like the food and beverage industry, food marketing, agriculture and food policies. For the social environment, it's your family, friends, and peers, which do play, a big role in eating behaviors. So we can't just view it as, oh, that person just doesn't want to eat healthy because they just don't. That's not the right way to look at it. So what is the state of nutrition education and medical training? So I will tell you that everything that I have learned so far about nutrition education is after my training. I remember in medical school that the only nutrition education that I had received was when it was related to like deficiency syndrome. So what I mean by that is what happens if you're deficient in a vitamin or a mineral. And that's not just inherent to my medical school. I love my medical school. There's no issue there. This is a problem with many medical schools around the country. So medical schools spend less than 25 hours of nutrition education over 4 years. So that doesn't average out to a lot every year. And studies demonstrate that, physicians were willing to learn about practical nutrition recommendations to help keep ourselves and our families and our patients healthy, but we just don't have the knowledge or the training to carry out this role. Despite knowing that, higher intakes of plant-based foods like fruits, veggies, leafy greens, whole grains, legumes, seeds, reduce the burden of cardiovascular disease and the morbidity and mortality of cardiovascular disease. But despite knowing all of this, we still just have overall poor diet quality in the US. So let's go into a patient case. So let's envision you and I, we're in the hospital. That's me really excited to be rounding with you this morning on the wards. So we're about to round on a very typical patient that I see on a regular basis in the post-cardiac surgery unit. So we're going to see Mr. Cardiothoracic. So Mr. Thoracic, he's 66. He has a history of diabetes, hyperlipidemia, which is high cholesterol in layman terms, hypertension, coronary artery disease. And he recently underwent what's called a 3-vessel coronary artery bypass graft procedure. See, Mr. Thoracic was recently diagnosed with the diabetes, hyperlipidemia, and hypertension just several months ago. His wife told him that he really needed to go and see a primary care doctor, finally, after many, many years. And so he finally went and he was diagnosed with those medical conditions. And then he presented to the hospital before surgery with some chest pain. And when we did our workup for his chest pain, we found that he had what's called multivessel coronary artery disease. So coronary arteries there's a right and left coronary artery, and they supply blood to your heart because your heart needs blood, right, to work. So unfortunately, he had multiple blockages that needed to be addressed with what's called a CABG procedure. So I am not a cardiothoracic surgeon, but I do want to bring this up because I want you to understand that a CABG is it's not a small procedure. It's a major surgery. Patients typically, spend 5 to 7 days in the hospital after a CABG procedure. Their first night's usually in the ICU. So essentially, when you have blockages of your coronary arteries, which are coming off of the first part of your aorta, which is the main large artery that supplies blood to your entire body through its branches, the only way, either you place a stent to open up the blocked vessel if possible, or if you have multiple blockages and an indication for a CABG, you undergo a CABG. So typically they take another blood vessel from your body somewhere else, like the radial artery or the lima, which is the left anterior mammary artery, or saphenous vein grafts from your legs. I know you can't see my legs. There's a couple of other areas that can also be grafted, and you have to bypass the coronary arteries that is blocked. So as you can see, it's not a small procedure. So I talked about some of his past medical history earlier. Past surgical history is that he had his gallbladder out many years ago, and then he just, of course, had the recent 3-vessel CABG. And then I want to just touch on the medications that he was on before he came into the hospital. So he was on lisinopril for his blood pressure, metformin and glyburide for his diabetes, atorvastatin for his high cholesterol, and a baby aspirin. He has no known drug allergies. And let's talk a little bit about the social history. So I think I take a little bit of a different social history. I mean, so social history is to understand, where does your patient live? Who do they live with? Do they smoke? Do they drink? Do they work? Are they retired? Do they, when I say drink, do they drink alcohol? And so it's a great section of the history that can tell you a lot about a patient. So in addition to the standard things that I asked, so Mr. Thoracic, for instance, he's a lifetime non-smoker. He does not drink any alcohol, which I'll mention why that's important. And he has never used any illicit substances. He's retired and married. Him and his wife are empty nesters. And so they both live in their home together alone. And so I take a little bit of a dietary, or kind of just what I like to call food history. So I asked Mr. Thoracic, where do you get most of your meals from, or who cooks at home? And so he tells me that most of his meals are consumed out of the home, or they're takeout, and they occasionally cook at home. And then I also ask about, do you have access to a kitchen? And I know that sounds very like, who doesn't have access to a kitchen? But you would be surprised at some of the answers that I get, because they may have access to a kitchen, like a sink, maybe like a countertop stove, but maybe they don't have an oven, or maybe all they have is a microwave. And so it's really, really important to find out what equipment is available to your patients in their kitchen. So he tells me that he has access to a kitchen with a fridge and an oven and a microwave. And then I ask him how he's been spending his time before coming into the hospital. And since the pandemic started, like many of us, we're probably binge watching some TV shows on Netflix. So let's go over his vitals and lab work. So I just want you all to take a moment here. And I know some of these values, I didn't put like what's normal next to them, but see if you can kind of spot what is abnormal. So I'll go over the vitals while I'm talking. Just think about what's not normal for him. So he's afebrile. His temperature is 98.1, heart rate's 88, blood pressure is 140/89. His BMI is 33.4, and his waist circumference is 42 inches. His lab work is notable for AST, which is a liver enzyme, and ALT, also a liver enzyme. They're mildly elevated. His hemoglobin A1C is 7.5%, which is elevated. His lipid panel before he came into the hospital, so his total cholesterol is elevated at 243. His LDL is 170, which is much higher than what we want it to be given his comorbidities. Triglycerides 201, and his HDL is 36. And then I want you to pay attention to his abdominal ultrasound, which talks about hepatic steatosis with increased echogenicity and no nodularity noted. So here's some of the abnormalities that really stand out to me. So I'm thinking, I'm like, hepatic steatosis. So in addition to knowing that he already has all of these, diabetes, high blood pressure, he's had coronary artery bypass graft, he has basically coronary artery disease that now has to be bypassed. He also has hepatic steatosis. So why do I care about hepatic steatosis? So hepatic steatosis is also known as fatty liver. Have any of you heard of fatty liver? I don't have the chat box open, but let me just see if there's, let's see. Okay, so fatty liver is, it's called, well, hepatic steatosis is also known as fatty liver. And the reason that we care about that is that, it's also known as non-alcoholic fatty liver disease. So let's just call it NAFLD to be more simplistic. It's basically your liver doesn't like excessive accumulation of fat. So NAFLD is characterized by accumulation of fat in the absence or without significant alcohol consumption. So I did mention that Mr. Thoracic doesn't drink, any alcohol. There's 25% of US adults have NAFLD, and of these, 20% are going to progress to what's called NASH, which I'll go over in just a second. So that's about 3 to 6% of the US population. So when you progress to NASH, which is non-alcoholic steatohepatitis, you're at risk of developing what's called end-stage liver failure. And end-stage liver failure, the only way to treat that, aside from managing the symptoms associated or the complications associated, is through liver transplant. And unfortunately, in the US, NASH cirrhosis, also known as end-stage liver failure, is becoming a leading cause of liver transplant. And if not already, number one cause, it's going to overtake it as the number one cause in the near future. There's no FDA approved medical treatments for NAFLD or NASH. And the mainstay of treatment to prevent progression to end-stage liver failure is lifestyle modification with diet and exercise. So going back to Mr. Thoracic, you see that he already has these comorbidities, but now we need to help him understand why the hepatic steatosis in his liver is also a potential future concern for him. And so we got to think about how are we going to help him prevent further comorbidity down the line. And so it's really crucial to identify patients with hepatic steatosis early to see if we can start implementing some of those lifestyle changes. And I actually see this hepatic steatosis a lot because my hospitalized patients, they end up getting a CT scan or abdominal ultrasound for some reason or another. And whenever I see that, I do talk to them about it. I do talk to them about their alcohol consumption, which can also cause fat infiltration in the liver. And so it's something that I want them to be aware of because otherwise it goes unnoticed. So this is a progression of NAFLD. You can see this is a nice healthy liver. And as the fat deposition increases, you start getting inflammation in the liver. So inflammation can cause the hepatocytes or the liver cells to die. And if we go back, we can see that Mr. Thoracic actually had a mild elevation in his liver enzymes, which means that they had to die for the liver and, the AST, ALT to spill into his blood for us to detect it. So, we were really worried about that. He's already got all these medical conditions. Like, how are we got to help him prevent further complications. And then of course, when NASH progresses to cirrhosis, this is really irreversible. And the only way to fix this is through liver transplant, which again is not, it's not a simple thing. You don't just get listed and get a liver. It's a pretty complicated process. So while you're talking to Mr. Thoracic on morning rounds, he expresses to you that, Doc, I need to make healthier changes in my life, especially with my diet, because you've told him about this hepatic steatosis, and you've really outlined that and I'll get to this later, you see this as a comorbid condition. The hepatic steatosis is often occurring in conjunction with diabetes or obesity, coronary artery disease, or cardiovascular disease. So those all kind of occur together. And so he's wondering, he's just feeling really overwhelmed. So, and he wants some guidance from you, like, how am I going to make changes in my diet? So what dietary patterns of eating can we recommend to Mr. Thoracic just for an overall healthy lifestyle and to benefit all of his medical conditions? So the key components of any healthy eating pattern are filling at least half your plate with fruits and vegetables. So I always tell my patients to eat the rainbow, focusing on whole grains instead of refined grains, which I'll talk about later. Consuming more legumes. I think the word legume probably isn't intuitive to a lot of people, but then I break it down like, is it beans? It's beans, it's lentils, peas, peanuts are actually legumes. Limiting ultra processed foods, and then remembering that supplements are not a substitute for real food. I get this question a lot from my patients of, oh, can I just supplement with X, Y, and Z and then I'll feel better, or this will make this better? And I often tell them that supplements are not they're not regulated. You aren't always getting what is listed on the bottle or what you're paying for. And I always emphasize healthy foods over supplements all day, every day. There are specific instances where supplements, certain, vitamin supplements are indicated, but that's not the norm. And then don't overlook the calories from liquids. So I, have patients tell me that, this juice is this is fruit juice stock. It's really good for me. And then, I have to turn the label around actually in the room with them and show them that, look, actually, it's not as good as you think it is. It has, 20 grams of added sugar, which I'll talk about how to read a nutrition label a little bit later as well. So kind of these are the tenets of healthy eating patterns. And then I also, like I said, try to ask patients in the social history part, like who do they live with, who does the cooking, who does the grocery shopping, where do they get their meals. But I always ask about soda intake. It's like the number one question that I ask is, do you drink soda? And then I ask, is it diet or regular, and how often? And then what I talk about specifically is that, the American Heart Association has recommendations for the amount of added sugar per day that is recommended. And each can of soda, no matter what the brand is like already above your daily limit. So if you're drinking 2 of those, then, you've exceeded it by quite a bit. And then, I try to use open-ended questions like, tell me about what you eat on a day-to-day basis. And the biggest thing to assess is willingness to change. So then I ask them, do you feel like you need to make changes in your day-to-day eating? And then I listen to what they have to say. And almost invariably, I have not actually had a patient tell me no. They have something that they want to change. And then I try to build off of that. And this is what I'm doing every day with them, because I actually have the luxury of seeing patients like several days in a row. And so I'm taking care of them kind of in a really vulnerable state where they want to get better from their medical conditions. They're feeling really open to making changes in their lives. And so I try to capitalize on that while I'm seeing them. So let's talk about healthful eating patterns. So who's heard of the Mediterranean diet? I'm sure many of you have heard of it. I know that I had heard of it even before in the past, but if you asked me in the past what the Mediterranean diet was, I'd probably tell you that it was, I heard it was like a healthy eating or something like that, something really vague that I wouldn't be able to explain exactly what it was or and why it's important. So the Mediterranean diet kind of came to fruition when there was an American physiologist, Ansel Keys, back in the 1960s, who noticed that people that lived in the Mediterranean region, like Greece, southern Italy, Crete, actually had lower rates of chronic disease and lived longer. And what he attributed that to was their dietary eating patterns, because these weren't patients, these weren't people that were accessing, or they had limited access to healthcare. So he felt that the health benefits or their longevity was related to the way they were eating. And so if you go into PubMed and search Mediterranean diet, you're going to get, I think I did it this morning just for fun, and it was like over 2,900 hits about the Mediterranean diet, because there is quite a bit of evidence out there that adherence to the Mediterranean diet, also known as the Med diet, plays a role in primary and secondary prevention. So primary prevention is preventing a disease from happening. So like from a vaccine, if you get vaccinated against hepatitis B, that helps prevent you from getting hepatitis B. And then secondary prevention is when you've already had the disease, but we want to prevent further complications or further deterioration of that disease process. And then something I should have emphasized on the previous slide, I say Mediterranean diet, but what I really mean is Mediterranean eating pattern. So it's not a diet in the literal sense that you often hear about, like, oh, this diet, that diet, follow this. It's not like that. This is meant to be a sustainable, lifelong eating pattern. It's been shown to be effective in preventing obesity and metabolic syndrome in healthy and at-risk individuals, and reducing mortality risk in individuals with overweight and obesity, decreasing the incidence of type 2 diabetes and cardiovascular disease in healthy individuals. So it's been studied quite a bit and shown to have some good benefit. So what are the tenets of the Mediterranean, eating pattern? So the base of this whole eating pattern is high consumption of foods that are from plant sources. So it's really a plant predominant eating pattern. And what I mean by that is it includes whole grains, it includes vegetables, fruits, nuts, and seeds. Olive oil is, specifically extra virgin olive oil, is the main dietary fat that's used in cooking. And it really emphasizes limiting the amount of saturated fat, so to less than 7 to 8% of energy, but just remember that it emphasizes saturated fat limitations. Includes eating red meat maybe like once or twice a month, and it's not something that it's recommended to be eaten like daily or weekly. I do want to point out the wine recommendations. So if you do drink alcohol, can consider drinking maybe 1 glass to 1 to 2 glasses per day. But if you don't drink alcohol, there's no need to start drinking alcohol just to adhere to the Mediterranean diet. I hope that makes sense. And really, when I say diet, it's like a lifestyle. So let me just go to the next page. So this is the Mediterranean diet pyramid. And as you can see, the base of the pyramid is this, tenet of being socially involved with your family and friends, being physically active. And then as you go up on the pyramid, again, you see that the majority of the base is plant predominant foods or plant-based foods. And at the very top is meats and sweets, which are supposed to be consumed less often. So they're not saying you can't have it. It's just that you don't want to, emphasize having it every single day, or trying to limit that as much as possible. And then when we talk about dairy in the Mediterranean diet, specifically the people that traditionally live in this area, they emphasize more like aged cheeses and yogurts, and not necessarily like milk products, or milk, I should say. And it does include some form of fish and seafood a few times a week. So there was a large interventional trial called the Pertinent study that was published in 2013 that basically looked at the effects of the Mediterranean diet and the development of cardiovascular disease. And they found that the trial actually ended early because they saw such a benefit in following a Mediterranean diet eating pattern with olive oil and nuts, and decreased incidence the decreased development of cardiovascular disease. In 2018, there was actually like a republication or kind of a redoing of the data of the study, because there was some problems with randomization that they found, but they generally still found the same conclusion, or they generally came to the same conclusions. But I wanted to look at some of the more kind of recent studies, or just to see what else was out there. And so about the Mediterranean diet and cardiovascular disease. So what I found is this systematic review, which is a review of a number of different studies. And what they do is they pool all of that information together. And this particular review wanted to answer the question of the Mediterranean diet and cardiodiabesity, which is a term that's not really mainstream, but it's used in literature to describe the link between cardiovascular disease, type 2 diabetes, obesity, and metabolic syndrome, which I'm actually going to post about that a little bit later on my Instagram. So stay tuned. But there's, a big link between all of these conditions. And so they came up with the umbrella term cardiodiabesity. And they did this systematic review to answer some clinical questions to help guide practice guideline development. And what they found was from a number of studies that there's a high level of evidence that demonstrates that adhering to the Mediterranean diet improves the health of individuals with overweight and obesity by reducing their weight and their waist circumference and lowering cardiovascular incidence and mortality. There seems to be a protective or a preventative effect of the Mediterranean diet on type 2 diabetes in individuals with and without risk factors. And then there was an evidence of preventative and therapeutic or so treatment roles of the Mediterranean diet adherence to in those with metabolic syndrome, which is a conglomeration of risk factors that increases your risk for cardiovascular disease. The mechanisms as to why the Mediterranean diet is considered beneficial really involves the food, it's around the foods that are emphasized in the Mediterranean diet. So it's thought to be that, plant-based foods are shown to improve some inflammation, help modulate or help your gut microbiota, its health, and help with glucose metabolism and lipid profile. So all of those benefits are attributed to the foods that are included in the Mediterranean diet, or emphasized, I should say. So a related eating pattern that's similar, but does have some differences to the Mediterranean diet is the DASH diet. And I had heard of the DASH diet when I was in medical school, but I didn't really know what it was. I knew that it was something that was related to lowering blood pressure, but I wasn't, I wouldn't be able to explain it to you at that time. And that's why I'm bringing it up since it's something I didn't know about. So the DASH diet, I kind of like to think of it as the Mediterranean diet, but more towards the American taste. And so it's also a flexible and balanced eating plan that helps create like a heart healthy eating style for life. So again, not a diet in the literal sense. It's meant to be sustainable, lifelong. It doesn't require any special foods. And again, very similar to the Mediterranean diet, it emphasizes vegetables, fruits, whole grains. It does include some more, like a more liberal amount of dairy products, which I'll talk about in a second. So it includes fat-free and low-fat dairy products, some fish, poultry, a little bit more often than the Mediterranean diet. So that's the difference. Beans, nuts, like 4 to 5 times a week versus like daily more in the Mediterranean diet, and vegetable oil. So if you can recall, I said that the main kind of source of fat in the Mediterranean diet is olive oil or extra virgin olive oil. And then, of course, just like the Mediterranean diet emphasizes limiting foods that are high in saturated fat, limiting fatty meats. And then I also want to add tropical oils to this, such as coconut, palm kernel, and palm oils. Yes, they're like vegetable oils, but they're from plants. It's a plant oil, but essentially it has a higher amount of saturated fat. So we tend to limit or avoid them. I don't recommend them as like a primary cooking oil. And then of course, limiting sugar sweetened beverages. So the DASH diet actually came to based on this study that was conducted by the NIH when they were looking for an eating pattern that could help lower blood pressure. And so the original DASH study, I think it was published in the 90s, 1997. So pretty old, probably as old as some of you guys, which y'all are young and not old. So this study included 459 adults. And so what they did is they randomized them to 3 different dietary eating patterns. And each dietary eating pattern contained 3 grams, of sodium per day. And so everybody kind of ate the same diet in the beginning as like the washout period, or to get everybody like on a stable plan, and then they were randomized. And so they were randomized to the typical American diet plus more fruits and vegetables, and then the DASH diet. So I talked about what the DASH diet was on the previous slide. And so what they saw is that within like 2 weeks, those that were in the typical American plus more fruits and vegetables and the DASH diet, they saw a reduction in blood pressure with just the diets alone. But that reduction was greater in those that were adhering to the DASH diet, and even more so in those that had pretty significant high blood pressure. So their top number, their systolic was above 140, and I think their diastolic was above 85. So those patients that were in that range, so higher than that, had an even more significant reduction in their blood pressure. And then there's been follow-up reports that saw that it helps improve your LDL cholesterol as well, which is, everyone refers to it as bad cholesterol, but it has been implicated in the development of coronary, cardiovascular disease and coronary artery disease. So I also was looking for some kind of more recent publications about the DASH diet and and health benefits, I should say. And so this was published in 2019. It's an umbrella review. So I talked about systematic reviews, which are a review of a number of different studies. So now we're taking a review of multiple systematic reviews. So essentially what they found is that the DASH dietary eating pattern was associated with a decreased incidence of cardiovascular disease, also coronary heart disease, stroke, and diabetes, and still they saw like the meaningful blood pressure reductions as well, and also a hemoglobin A1C reduction for those that were diabetics. So, like I said, they include a lot of similarities as far as like the foods that they emphasize. The DASH diet's a little bit more structured. They give a little bit more guidance as far as like how many servings to eat per se. But the main thing that I want to emphasize is that, as far as like poultry for the Mediterranean diet and poultry for the DASH diet, I think the DASH diet allows a little bit more flexibility on how much poultry you may be eating and fish you may be eating and lean meats versus the Mediterranean diet, which emphasizes kind of limiting that amount to less than the DASH diet. And then I talked about the olive oil and the vegetable oil difference. Sweets are also less emphasized in the Mediterranean diet. Here in the DASH diet, they do include like a moderate amount of 5 sweets per week. So either way, both of them are considered healthful eating patterns. I think the USDA recommendations actually emphasizes more of a Mediterranean eating pattern, but both of them have been shown to have benefit in a multitude of chronic medical conditions. So, and the one point that I want to make about dairy. So I think there needs to be a distinction between dairy being a necessity and dairy being a personal choice and consumption on a day-to-day basis, if that's what you want to include in your eating pattern. So, dairy is not a necessity. I know it sounds crazy. Somebody told me that like 10 years ago or 5 years ago, I'd be like, what? But you don't need it to live. You can actually there's plant sources of calcium. There's plant-based milks that are fortified with vitamin D. You could also supplement with vitamin D. Make sure you talk to your healthcare provider or your physician. So you don't need dairy. So if you do include it, it should be viewed as like a personal choice versus a necessity. I hope that makes sense. What advice would you give to Mr. Thoracic to start eating healthier now that you've learned about 2 healthful dietary eating patterns? And let me see if there's any questions that I can answer in 1 second. Okay. Let's see. Okay. So, what dietary changes would you recommend for patients with? Actually, let me focus on this question. I'll answer these towards the end. So, I want to see if anyone has any thoughts or advice that they would give to Mr. Thoracic to start eating healthier. So, I'll pop back in the chat box in just a second. I think we're still pasting. Okay. So when I talk to patients about healthier eating patterns, I actually have this particular diagram on my phone. And what I do is I pull it up and I showed them. I was like, look, I'm not asking you to give up everything that you have been eating. I'm asking you to, think of your eating pattern and how can we make it healthier step by step. And then I give them this visualization and I say, look, this is what my plate, and this is what my plate looks like. Or I try to make sure this is what my plate looks like whenever I'm eating. I like this better. This is from the School of Public Health at Harvard. I like this better than the USDA Choose My Plate because it does have some more information. So as you can see, that half of the plate is fruits and vegetables, and part of it is whole grains, and that could include things like quinoa or brown rice or bulgur or amaranth. There's a lot of different whole grains out there. I personally swapped out all of my white rice in the beginning when I was learning, or trying to find ways to eat healthier. I just swapped out my white rice for brown rice or quinoa, and it's worked out really well for me. And then there's an emphasis on healthy protein. In my case, I love lentils and beans. I really try to incorporate at least a serving of those into my meals. And so, but whatever healthy protein of choice that you like, and this really emphasizes just an overall healthier eating pattern. Oops. Okay. So Mr. Thoracic decides that he would like to try to work towards a Mediterranean diet eating pattern, and you recommend that he pick one or two things to change about his day-to-day eating. And then once those changes feel like second nature, he can continue building. So I don't expect somebody, I don't expect my patients to go home and then just completely revamp their way of eating in one day. That never happens. And also it's not sustainable. Every time I've tried, and I've tried in the past, I did try in my 20s many times to eat healthier, or I basically just eat salads for all my meals, it wasn't sustainable for me in the past. I think I would adhere to it for about a week or so. But what has made sense for me is making small changes, and small changes add big. So one of the things that I have changed in my own eating is, like I said, swapping out refined grains for whole grains. And so that's where I started. And from there, I started building. And now it's just really second nature to me. And I realized just how flavorful healthier foods can be. So I want to make a few important points about the specific components of a healthier eating pattern. So something I didn't appreciate or know much about in the past is something called phytochemicals. And what phytochemicals are bioactive compounds that are innate or native to plants that are there for their own protection. That's how they protect themselves against stressors like the weather or like insects. And essentially, those bioactive compounds are beneficial to us whenever we eat the plant. So I think of it as a benefit to eating plants, or just an added bonus. There's more and more, I don't even know how many different types of phytochemicals out there. I think I read 10, 20,000. I mean, there's a lot of different ones, and they're only found in plant-based foods. And they're thought to, have the antioxidant, anti-inflammatory role of plant-based foods. That's what it's attributed to. And so whenever I'd heard this, I was like, oh my gosh, this is so amazing. But, the research as far as like phytochemicals and health benefits is still, it's still coming out. It's still, in process. And I think it'll never end because there's just so much to learn about phytochemicals out there. But whenever you eat plants, you get this added benefit for sure. And then I want to talk about, I kept referring to saturated fat and unsaturated fat. So if those of you that are taking biochemistry, you may already know this, but saturated fats are basically when there's single bonds between carbons. And the way to identify saturated fats is that they're usually solid at room temperature. And so unsaturated fats is when you have one or more double bonds between carbons, and they're mainly liquid at room temperature. And then when you divide unsaturated, and this could be a talk in and of itself, but when you divide unsaturated fats out, you have polyunsaturated fats and monounsaturated fats. So mono means one double bond, and then poly is that there's multiple double bonds. And like for instance, like cooking oils that are rich in monounsaturated fat include extra virgin olive oil, avocado oil, canola oil. And then there's polyunsaturated fat, which when you break it down, it's omega-3, which is alpha linoleic acid, and omega-6, which is linoleic acid. Linoleic acid, I'm saying these wrong. So it's those terms you've probably heard, but just understand that that's under the umbrella term of unsaturated fat. And so examples of saturated fat include basically any animal, red, like especially red meat based type of product. So beef fat. There's also butter. I talked about coconut oil. Dairy products also have a lot of saturated fat. Pork fat like lard, shortening, Crisco. So there's quite a few sources of saturated fat that are present in quite a few foods. Sorry, guys. And then I want to talk about the difference between a refined grain and a whole grain. So a whole grain is whole. And what I mean by that is that you still have the bran and the germ, which are, the bran is like the fiber-filled outer layer, and then the germ is also packed with phytochemicals and vitamin B and vitamin E and the healthier fats. And then when you refine the grain or make the grain refined, you lose the bran and the germ, and essentially you're left with the endospore, which is not as nutrient dense. And so one thing that I tell my patients all the time is that when you're looking at like wheat products, if it just says like wheat flour as the first ingredients, that's actually from a refined grain. It's not from a whole grain. You need the words like whole wheat or whole grain to really tell you that it still has all of the nutrients of a whole grain. I hope that makes sense, because a refined, like wheat just kind of means it's refined flour. It's like white flour essentially. And then how to properly read a nutrition label. So the FDA actually recently changed or mandated changes in the nutrition label to manufacturers, and they made some key changes. One of the ones that I want to point out is that this label on my right-hand side now includes the number of added, the grams of added sugar. And so the old labels actually just listed like sugar, like 12 grams. You didn't know what was added or what was inherent to the food. So it's really, really important to understand. I emphasize this to my patients. And if I see juices in their room, I turn that label around and I'm like, look, you need to know that this is now 20 grams of added sugar. And they are like, oh, doc, I didn't realize that. And so it can sneak by you. And then I want to emphasize the serving size, because I think there's a lot of confusion around the serving size. I think people think, or I used to think actually, that the serving size means that it's like the recommended amount of food that you're supposed to be eating. But taken straight from the FDA's website, the serving size is not a recommendation of how much to eat or drink. In fact, the serving size is based on how much we actually are eating and drinking of a specific product in the US. And so, for instance, the serving size of soda increased from 8 ounces to 12 ounces, just because I guess we're drinking more soda, which is not surprising. And so that doesn't mean that you should just start drinking 12 ounces of soda. I hope that makes sense. And then the for instance, if a serving size of like a frozen vegetable says it's 1/2 cup, that doesn't mean you have to like limit yourself to 1/2 cup. That just means that's what we're eating on average whenever we do eat frozen vegetables. And then just a culinary medicine tip, or just a culinary tip in general. One of the things that I wish I had invested in a lot sooner was a chef's knife. So like I said, in residency, I never cooked. My kitchen was completely empty. It was clean because I just never used it. And so I think one of a time-saving tip was investing in a chef's knife, because it actually makes it easier and faster for me to prepare my vegetables and my fruits. And this is my chef's knife, so I decided to bring it along for this demonstration. But basically, you have a long blade. It could be like 8 to 12 inches, and you want to look for a chef's knife that has the metal part that goes all the way through the handle. And why you want that is it gives you a nice balance feel, like the handle's not floppy. It's got some oomph in my, my fist. And so it's not moving around when I'm cutting. And then you want a handle that really fits your fingers and your hand to reduce fatigue. And then the way I grip a chef's knife isn't by the handle. I actually use my thumb and my index finger, and I hold it at the base. And this gives me a lot more stability when I'm cutting. I'm sure you guys were not expecting me to bring a knife out, but I just wanted to show y'all. And so again, this is just a picture of the blade going, or the metal going through the blade, which keeps it balanced. And the last thing that I want to leave you all with is something that I didn't appreciate in the past, but of course, we are all trying to be, mindful of our impact on the environment. And one of the things that a lot of people don't appreciate is kind of the impact of food production on our environment. And so I took this from our worlddata.org, and you can see that food production accounts for 26% of global greenhouse gas emissions. And when you break that down further, you can see that the top kind of 5 offenders of greenhouse gas emissions across the supply chain include beef, lamb, cheese, and chocolate. But beef, by the way, the beef herd is like proportionately a lot more resource intensive than other like cheese, for instance, or chocolate or coffee. So what I'm bringing this up because I keep talking about healthful dietary patterns, emphasizing a reduction in, red meat consumption, which is high in saturated fat. And I think in addition to our own health, you can, if you could consider it also for the health of the planet, then it's a win-win situation. And then a few of my, let me see what time it is. Okay. Oh, I'm right on the dot. So a few culinary medicine tips for making healthy eating easier. So some things that I think about are the protein and the dessert flip. And the protein flip, I'm not really sure who coined that term, but if you go to the Culinary Institute of America and look at their Menus of Change initiative, they have this huge like flyer and document that talks about the protein flip. And it's like encouraging chefs to think less about equating protein with like meat, and making protein like the sideshow or meat the sideshow of a dish, for instance, or like more like a garnishment, I should say. So instead of having like half of your plate with a steak, maybe the steak is just a small part of your plate, or it's used as garnishment in your salad. I'm not sure exactly, but like as in like, that's the concept, but I'm not sure what like the original definition was meant to be or where that term came from. And then the same thing with dessert flip. So something that actually really helped me. So when I was eating a lot more ice cream, I would probably add a little bit of like fruit to it. And then I realized that I really didn't need that many bites of ice cream. I just needed a few bites to satisfy whatever craving I had. And then I filled the rest of my bowl with fruit. And I honestly find that really satisfying. So try it out. I love strawberries. So that's kind of like my fruit to go to. Replacing sources of saturated fat, like I talked about, with sources of unsaturated fat. And then really important, start off by making small changes. If you try to change too much all at once, it's not sustainable. And, be patient with yourself. It's like I said in the beginning, like that quote that or what I said in the beginning is that, it's never too late to start making healthy lifestyle changes. And we're looking for progress and not perfection. When we think about making something perfect, it becomes daunting. It becomes like this hurdle that we have to overcome, and it can be really disheartening. So I don't, when I go and talk to my patients, I try to, assess their understanding of the changes that they want to make. And then I give it to them and, talk to them about it in little bits. I don't try to overwhelm them all at once. And then talked about investing in a good chef's knife. Meal planning, I know that sounds really intuitive, but it's not actually intuitive. And it wasn't intuitive to me. And so just setting like a small part of my week out and just jotting down what I want to eat during the week. And that doesn't mean I have everything planned out to the T every day, but it helps keep me on track so that I'm not reaching for things that are less healthier. I also, I'm really interested in finding ways to reduce food waste. And so one of the things that we can all do on a home level is taking inventory of what we have already. So I try to organize my kitchen in a way that I can see everything so that I'm not buying I'm not even kidding. Like there was this one time that I think I'd bought like many cans of chickpeas because I kept thinking I didn't have any, and then I found all 10 cans. So it's a way to help save money and reduce food waste. And then batch cooking. I know, again, that seems really intuitive, but what batch cooking is that instead of making smaller quantities of foods, you're making larger quantities and kind of repurposing the food. And for instance, like brown rice, like instead of making 1 cup, I'll make 2 cups, and then I'll eat it with my lentils, or I'll put it in like a Chipotle style bowl, or I'll, stir fry it with some veggies and some sauce and make fried rice out of it. I did this last night. I had I think it was like Trader Joe's risotto, which is I think it's like a red lentil and chickpea based kind of like rice alternative. And so instead of just making like the cup that was on the directions, I ended up just making the whole box. And then my husband and I have our meals for a couple of days. So it was nice. Make sure you read your recipes carefully. I do spend a little bit of time, chopping some vegetables up at the beginning of the week or sometime in the week. And it makes it easier, like onions, for instance. Like if I know that I'm going to be using onions throughout the week for multiple things, I just chop it up, keep it in a big container, and then I don't have to keep doing that over and over and over again. And I know it seems like, oh, it's going to take forever for me to chop this huge onion, but it does save you time in the long run. And then one of my favorite things to do is roast a few different vegetables in the oven and keep it aside as like my sides throughout the week. So last night it was asparagus. I just took my asparagus, cut off the hard parts, preheated my oven to 400 degrees. I put a little bit of olive oil and kind of coated the asparagus in there. And then I roasted it for 17 or 18 minutes. I put the spices on at the end. I don't pre-spice it and roast it. That's the way I prefer it. I think it tastes more flavorful that way. And then advice for your future in medicine. So make sure you truly understand why you want to pursue medicine, why you want to be a doctor. Being Indian, I grew up with my family members, my parents telling me, oh, go to medical school, be a doctor. And I'm sure many of you can relate to that sentiment. But I ended up, becoming a physician, not for my parents, but for myself. And I know they're proud of me, but the road is long, it's rewarding. It's, I would not have any other career. I enjoy helping, patients feel better. And I enjoy especially as a hospitalist, the acuity of care. I enjoy thinking about the disease processes, especially as an internal medicine physician. I see so many different disease processes and trying to think about them. It's really a quite cerebral field, I should say. And so there's no other career that I would have picked for myself. Take your MCAT early. So if you're in a state that has rolling admissions, you want to, and what I mean by that is that if you're in a state that starts looking at applications in the order that they're receiving and handing out interviews in the order that they're receiving, you don't want to be in the late part of that application cycle because they have less interview slots. You want to be in the beginning where, you know, things are, the schedule is more open for interviewing, especially if you don't have the best like GPA or MCAT. And so I do recommend taking the MCAT early and giving yourself enough time in case you need to take it again. And I recommend getting your application in, especially I'm from Texas. And so when I was applying, there was rolling admissions. And so I got my applications in like on, I think like the first day that I could get it in. So definitely do that early. Start to identify potential letter writers like now. Many of you will be, I'm sure, applying next year in the summer, and you want to give your letter writers time to get to know you. If you're like a freshman or a sophomore, always kind of keep in the back of your mind, like, oh, this professor, I've, you know, done research with them, or like they know me really well, they know my work ethic, like, you know, this is somebody that I want to keep in touch with. So start thinking about all of those things now. And then I think the most important piece of advice I could give you all is don't feel pressure to apply if you aren't ready. Like I said, I didn't do very well in my freshman year of undergrad, and it really made my GPA not what I wanted it to be. And I do wish that I hadn't applied when I did that first time, but that's okay. It was a learning experience for me. But don't feel like you're on anyone else's timeline or anyone else's journey. Like your journey is unique. Everybody around me was like applying, and I just, you know, I felt a little bit of pressure, and also my parents. And so just try to drown out all the noise and then apply when you're ready. And don't, in life, you know, just because things don't happen the way you want them to doesn't mean that they don't happen the way they were supposed to. And I look back on my journey, I look back on how I, you know, got to this point, and I don't think there would have been any other best way, to be honest with you. And then this is just a funny meme for all of you. And so thank you so much for being here and allowing me the opportunity to talk to you about my passions, my love for medicine, my love for culinary medicine. And the easiest way to connect with me is on Instagram at my handle, Dr. Patel. So I'm Dr. Patel, and my husband, who's like really, he's a very clever man, came up with my name. So I'm very proud of it. All right, okay. Let's see, I think we have some questions. Oh, what's the difference between someone who practices culinary medicine and a nutritionist? So I think what you're referring to is like a dietitian. So dietitian, you know, they spend many years training and learning about nutrition, and they are an integral part of our healthcare team. And so we work together to take care of our patients. So I talked to you about like all the members of the healthcare team in the beginning, all the people that I work with, and a dietitian is like the integral part of a healthcare team. And so you know, obviously I didn't have that kind of training, and they definitely know a lot more than I do when it comes to nutrition. So I think we both have unique aspects to add to our patient care. And I'm glad, I love learning from them. I ask questions to them all the time. I may, you know, start the conversation about a Mediterranean diet, and then I'll ask them to help me reinforce that, or they'll, and so we work together to really, to accomplish both the ultimate goal of taking care of our patients. Would you consider your specialty to involve more preventative medicine, or do you also use eating habits as a way to help people treat, manage current illnesses? So that's a great question. So since I don't work in the primary care setting or a clinic setting, I'm seeing the patients after they've already usually been diagnosed with medical conditions, and now they're having a flare of it. But sometimes I see patients that come in and they had no idea that they had like diabetes, and they're coming in with blood sugars in the 500s, and they had no idea that they had high blood pressure. And so I do catch those patients too. And so I think the way I try to help patients is helping them with their current illnesses and prevent them from having future exacerbations by talking to them about their dietary habits and ways that they can change it in a practical way while I get to spend this time with them in the hospital. Would you recommend using sugar substitutes like monk fruit or stevia? So, especially in patients that are maybe drinking a lot of sugar sweetened beverages, so like added sugar, I do think it's a reasonable option to, swap those sugar sweetened beverages out with beverages with monk fruit or stevia. Personally, I'm biased and I think water is like the best thing to drink. But it's not a bad option, especially when you're trying to help a patient cut back down on their added sugars. Oh, thank you. Yeah, DASH diet is great. Start cooking at home more. This is in reference to Mr. Thoracic on how we would help him. Do you encounter many patients with eating disorders? I don't, but I will tell you this. My goal when I give my patients any advice is, and my this is so important, is that I want everyone that I encounter, everyone out there to have a healthy relationship with food. We don't want patients to feel a certain way that leads to, a certain negative way that leads to disordered eating. So I'll be honest, like in the past, like when I was trying to eat healthier, and then I would maybe have what I considered a slip up. I would, feel really, really bad about it. And I would be like, oh, I got to go and like run 4 miles to run this off. And it's just kind of a perpetual cycle and you feel really guilty. And I don't want people to have that kind of guilt. I want them to understand why it's important to eat healthier and start making those small changes for themselves, like from inside. Yeah, can you do culinary medicine alongside different specialties such as cardiac and pediatric medicine? Absolutely. This is a field that is for everyone. I mean, it doesn't matter what specialty you are. It's not just for physicians. There's nurses, nurse practitioners out there even. There's a lot of different healthcare professionals that are, getting culinary medicine training because we all see patients in a different context. And I think there's a lot of benefit to be had with this added knowledge. I think, it's getting back to the basics and thinking about what we are eating and how that affects our health and how we can use that knowledge to prevent exacerbations, to augment treatment. Absolutely. Okay. All right. I think what dietary changes would you recommend for patients with conditions like IBS where eating legumes can cause gas and stomach pain? That's a great question. So full disclosure, I also had quite a few symptoms with IBS and legumes and the increased fiber, which is kind of causing an overall like stomach upset. I would say that, you want to gradually increase the amount of fiber that you're eating. So I wouldn't, go from like 0 to 60 in one day, especially with legumes. So I do realize that I saw the symptoms more when I was using like canned garbanzo beans, for instance. And so I ended up just soaking garbanzo beans overnight and using that in my food and noticed some less symptoms in that aspect. I will say now, I don't actually have, personally, anecdotally, I don't actually have the same IBS symptoms that I did in the past. And I think that's just overall related to like the way I'm eating. So, and there's actually some great, I'm not sure. Oh yeah. If you want to message me, on Instagram, there's some great IBS dietitians out there that I can refer you to. I follow them on Instagram as well. Okay, all righty. I think time is up. Is there any more questions?
I think you covered all of the ones I put in the chat. Thank you so much for taking the time to answer those questions at the end. And thank you so much for a wonderful presentation. I know everyone learned so much. For everyone still watching, the Google form to track your attendance will be posted in the chat box. So if you guys can fill that out in the next 30 minutes, I'll close it at 3:50 p.m. Eastern time. And thank you so much again, Dr. Patel. This was wonderful.
No problem.